Hello, I'm Dr. Jonathan Bromboz. I graduated from the University of Notre Dame and Loyola University in Chicago. I completed a hospital rotating internship in dentistry at the United States Public Health Service Hospital in San Francisco. I am a member of the International Association of Oral Medicine and Toxicology and a fellow of the Academy of General Dentistry. This overview concerns the oral systemic connection and how periodontal gum disease is a central player in inflammation and other systemic conditions in the body. Dentists can help physicians and physicians can help dentists prolong the life of their mutual patients and decrease the incidence and severity of systemic conditions. The majority of the population has gum disease to a greater or lesser degree. A proactive referral to a dentist who has a focus on periodontal disease and utilizes the latest treatment modalities can treat the disease simply and efficiently with low post-treatment morbidity. This can decrease overall systemic inflammation levels and markers and occurrence of numerous diseases. There are several types of inflammation. There is acute local inflammation and chronic long-term inflammation. And when the inflammation turns on the body itself, attacking itself, it becomes systemic inflammation. We will discuss briefly the inflammatory cascade of events that can be initiated by both infectious agents such as bacteria, viruses, and parasites, but also by xenobiotics, those foreign chemicals not natural to the human body, such as toxins, drugs, antibiotics, poisonous agents, such as heavy metals and other chemicals. When the infection by oral bacteria releases metabolic waste products, such as fatty acids and lipopolysaccharides, endotoxins, and other bacterial components into their local environment, the immune system is alerted by chemotactic chemicals calling in the white blood cell troops. The B cells are the source of immunoglobulin antibodies like IgM, IgA, IgG, IgE, and IgD. The T cells' cellular immunity from the bone marrow cells after migrating to the thymus have the function of killing foreign tissues and to produce lymphokine inflammatory proteins. These are large proteins that regulate other cells of the immune system. Some of the lymphokines are interleukins or cytokines, of which there are a couple of dozen types. T cells are also the source of interferon, granulocyte macrophage colony stimulating factor, and tumor necrosis factor. Other components of the immune system are the nonspecific complement system and the phagocytic cells, the macrophages, and neutrophils. When acute inflammation persists, it transforms into a chronic and systemic inflammatory situation, with freely circulating interleukins and other cytokine proteins mediating even more inflammation. These polypeptide cytokines have acute or chronic inflammatory properties. Interleukin-1 beta, interleukin-6, and TNF-alpha are extremely potent inflammatory molecules and have both acute and chronic properties. Their effects include the ability to stimulate production of collagenase and proteases, induce fever, and cause the liver hepatocytes to produce other acute phase reactant inflammatory proteins such as C-reactive protein and prostaglandin E2. PGE2 elevates the risk for early preterm low-weight babies and other pregnancy complications by a factor of 780%. These liver-produced acute phase reactant proteins can in turn circulate through the body and produce secondary tissue injury by virtue of their own actions. These inflammatory proteins can be measured in the circulating blood and serve as markers or indicators of inflammation occurring in the body. Other available laboratory tests include high-sensitivity cardiac C-reactive protein, interleukin-6, tumor necrosis factor alpha, interleukin-1 beta, and interleukin-8. The new evidence shows that high-sensitivity C-reactive protein levels are more predictive of future cardiovascular events than cholesterol alone. But the predictive value of the two component measurements when added together is even more remarkable. In severe bacterial infections, levels of C-reactive protein can increase from less than 10 milligrams per liter to over 1,000 milligrams per liter or more. A cardiac high-sensitivity C-reactive protein test is necessary because, according to HK and CDC guidelines, it is the small changes of the range under 10 milligrams per liter that is most predictive of elevated cardiovascular risk. Below 1 milligram per liter is low cardiovascular risk. Between 1 and 3 milligrams per liter is average cardiovascular risk. Between 3.1 and 10 milligrams per liter is high cardiovascular risk. Persistent elevations above 10 milligrams per liter may be indications of non-cardiovascular inflammation. This data comes from Ridker et al., published in the New England Journal of Medicine in 2000. C-reactive protein is a general marker of the presence of inflammation, while interleukin-6 is a more specific marker. Periodontal disease infection can drive CRP levels higher and significantly contribute to deleterious systemic inflammation. Treating and eliminating periodontal disease infection can reduce CRP levels and also arrest the influx of bacteria and toxins into the bloodstream. With the new advances in the treatment of periodontal disease, this very prevalent oral infection can easily be eliminated in a quicker and more efficient fashion than the conventional periodont therapies of the past that involved cutting and sewing surgery of the gums and the much dreaded postoperative discomfort. Handling periodontal disease is quicker and easier than ever with high impressive success rates. Periodontal gum disease, as a significant major contributing factor to many medical conditions, can efficiently be eliminated with low morbidity. Highly organized symbiotic bacterial colonies of 400 to 2,000 different species develop an exquisitely resistant biofilm on teeth and gingiva. These adhesive biofilm colonies on the teeth and gingiva is also known as dental plaque. The general public has been so desensitized to the term dental plaque or plaque by television and magazine advertising that I rarely use the term plaque, because it diminishes the true, serious, deleterious nature of the dental bacterial biofilm. These masses of invasive bacteria, along with inflammatory proteins, cause a breakdown of the oral tissues, allowing the invasion of remarkably motile microorganisms into the tissues and into the vascular system and into the general circulation, to lodge in the lining of blood vessels and inside other major organs of the body. Recent DNA studies show that over 50% of the microorganisms in the mouth have DNA that does not match the microorganisms in the mouth that are culturable. So 50% of the organisms in the mouth that the mouth harbors are not identifiable. The reference is the Journal of Clinical Microbiology, July 2005. In another study, the oral bacteria Porphyromonas gingivalis was placed in culture with human cells, and within minutes, these bacteria were inside the cells. Porphyromonas gingivalis produces hundreds of types of toxins. One of the most vicious toxins Porphyromonas gingivalis produces is heat shock protein 60. Heat shock protein is an early evolutionary protein that is retained in plants, bacteria, animals, and including humans. Heat shock proteins are responsible for maintaining the integrity of cellular proteins in response to environmental changes, such as temperature changes, pH change, and toxins. All can initiate heat shock proteins to maintain conformation of the cell's proteins. Heat shock protein 60s have a function in the transport and maintenance of mitochondrial proteins and also the transmission and replication of mitochondrial DNA. There is evidence that heat shock protein 16s can be found in the surface of cells and even released from cells to function in immune response signaling in response to infection and stress. It has been shown that heat shock protein 60 is able to activate monocytes, macrophages, and dendritic cells, and also induce secretion of a wide range of cytokines. Heat shock protein 60 response may be a part of the danger signal cascade to the immune system. There is mammalian as well as bacterial heat shock protein, and they are similar in sequence. Lymphocytes taken from periodontal patients with periodontal disease were found to have antibodies against heat shock protein 60. Those lymphocytes recognize the heat shock protein 60 of Porphyromonas gingivalis. The B cells recognize and make antibodies against the bacterial heat shock protein 60. But unfortunately, due to the antigenic similarity between bacterial heat shock protein 60 with human endothelial cells, the B cells attack antigenically similar human endothelial cells and sets the stage for cardiovascular disease. To summarize, the immune system makes antibodies against oral bacterial toxins. These antibodies cross-react against the endothelial cells lining the blood vessels. Small amounts of bacterial toxins ramp up the immune system to produce sufficient cross-reactant antibodies to initiate autoimmune response. Bacteria produce the toxins, the body reacts to the toxins, antibodies are made to attack the toxins, but unfortunately, at the same time, they attack our own tissues, resulting in autoimmune disease and cardiovascular disease. Researchers have found heat shock protein 60 specific T cells in patients with cardiovascular disease and atherosclerosis. The reference is Clinical Diagnostic Laboratory Immunology, February 2005. Also, Kozyrev et al. In Arteriosclerosis, Thrombosis, and Vascular Biology in 2005 reported that human atherosclerotic plaque contains viable, invasive Actinobacillus actinomycetum comitans and Porphyromonas gingivalis. It has been proposed that the mouth acts as a reservoir for Helicobacter pylori involved in ulcers and gastric cancer. The deep space between the gums and the teeth is called a pocket or a gum pocket. It is technically considered to be outside of the body, and it is not easily accessible to anti-infective agents and the body's defense systems. Plus, H. pylori can be resident in the inner portions of the biofilm on the teeth and under the gingiva. Also, H. pylori can reside inside the hardened mineral-like calcium material called calculus or tartar that builds up on the surface of the tooth and on the root of the tooth below the gums. Buried inside protective layers of biomass or inside concreting mineral deposits or reverting to spore forms, microorganisms can survive even the most aggressive multi-antibiotic combination therapy. Only aggressive debridement with high-power ultrasonics and laser energy disinfection applied site-specifically can eradicate the bacterial reservoirs. Simply starting to floss and brush your teeth better will not handle the condition. Once these stubborn bacterial biofilms, both hard and soft, establish a foothold on the teeth and under the gums subgingivally, it requires a multi-step program in order to eradicate the infection. In a high percentage of patients, periodontal disease advances without any symptoms whatsoever to a severe condition. By the time a person has loosening teeth, bleeding gums, halitosis, significant invasion of toxins and microbes has been occurring and the condition is far advanced. Subclinical periodontal disease may be advancing for years before any observable symptoms. Simply looking at the mouth cannot diagnose periodontal disease. It requires an early screening visit to the dentist and intraoral periodontal probings to measure the depths of the pockets or deep spaces between the gums and the teeth, and x-rays to adequately diagnose the condition. In over 3/4 of the patients I diagnosed with periodontal disease, they have no clue that the condition was present. Oral periodontal infection is pandemic. Studies have shown that 80% of the population has periodontal disease gum infection to some degree or another, and many of them are good toothbrushers and make a decent attempt at their oral hygiene. In a prospective longitudinal study published in January 2005 of diabetes care, Dr. Robert G. Nelson of the National Institutes of Diabetes and Digestive and Kidney Disease in Phoenix, Arizona, and colleagues reported that those subjects with severe periodontal disease had a 28.4% death rate, and those with little or no periodontal disease had a 3.7% death rate, more than a 7-fold difference in the death rate. Periodontal disease is linked to heart disease, cardiovascular disease, worsening diabetes, pregnancy complications, kidney disease, lung disease, low-weight preterm babies, obesity, arthritis, stroke, osteoporosis, Alzheimer's disease, colon cancer, pancreatic cancer, prostate cancer, atherosclerosis, hypertension, and ulcers. Immune system dysfunction is driven by several factors. One of the factors is the genetic susceptibility to autoimmune disease. Another major player are environmental factors, such as foreign xenobiotic chemicals. These xenobiotics and chemicals bind to human tissue antigens, forming haptens, and bind to DNA, causing the macrophages and T cells to respond and misidentify our own tissues as foreign. And with cooperation between the T cells and the B cells, antibody production occurs. Antibodies against cellular proteins lead to conditions such as skin rashes, cardiovascular disease, rheumatoid arthritis, inflammatory bowel disease, and lupus-like symptoms. And reaction against kidney tissue leads to kidney disease. Allergic cross-reaction with neuronal cells leads to autoimmune nervous system disorder and multiple sclerosis-like symptoms. Dipeptidyl peptidase is a protease that breaks down proteins. It is also known as DPP4. Trypsin or chymotrypsin breaks down proteins to peptides, and peptidases break down the peptides to amino acids. Secretory IgA is an immunoglobulin that is made by the plasma cells and secreted by the mucosa. It is the principal immune system antiviral, antibacterial, and first line of defense of moist mucosal surfaces. Many bacteria make different types of DPP4 proteases, and some of them break down secretory IgA. DPP4 produced by bacteria act as collagenase and gelatinase, breaking down the tissue, allowing bacteria to invade the mucosa. Fibronectin is a cellular adhesion glycoprotein. Bacteria bind to the fibronectin on epithelial cells, and then bacteria release their toxins and proteases to damage the tissue cells. Strains of bacteria that produce high levels of DPP4 produce significant tissue damage very rapidly, ahead of the arrival of phagocytes and mononuclear cells, and before any inflammation is present. These high DPP4 producing bacteria then invade the tissue, secreting more toxins and increasing the tissue damage. The real-world implications are that periodontal disease is now considered an independent risk factor for heart disease, stroke, diabetes, and many other systemic conditions. In surgical risk cases, the periodontal disease infection can be eliminated and the gum pocket sterilized and the tissue disinfected in very short order with the new PeriLase patented laser technology and protocols, in days if necessary. Periodontal disease is widespread, with reported 80% of adults having some form of chronic oral inflammation, with 25 to 45% having moderate to severe manifestations of frank periodontal disease. A majority of existing patients are at risk for major medical problems. In severe periodontal disease patients, the calculated surface area of the infected gingival collar around the teeth is equivalent to the concave area in the middle of the palm of the patient's hand. This is up to 36 square centimeters of open suppurating infected wound tissue. This necessitates a preemptive referral of patients to competent dental professionals to handle the periodontal disease. My interest as a dentist is to eliminate periodontal disease as a source of systemic inflammation, and the oral tissues as an entry point for bacteria and endotoxins into the general circulation. In the majority of cases where the chronic periodontal infection is controlled, laboratory tests for HbA1c and high-sensitivity C-reactive protein show a reduction. It is important that physicians and dentists work together, and that physicians refer their patients to dentists for screening for oral periodontal infections, and that dentists begin referring their periodontally involved patients to physicians for evaluation and management of the comorbidities attended with the states of chronic inflammation. Traditional periodontal treatment programs, which do not focus on the vital factors to handle disease successfully, are at best a periodontal management strategy, attempting to control the condition rather than definitively eliminating it. Traditional surgery is done at the expense of supporting bone and gum tissues and is associated with high post-op morbidity and decreased long-term patient compliance. I have optimized a periodontal treatment program that is very effective for my patients with low post-treatment morbidity. It is a comprehensive program that manages the disease not only through culture and sensitivity testing, systemic antibiotics, ultrasonic debridement, and scaling of the teeth, but curettage and sterilization of the diseased tissues employing a laser. Patient education, management, and training of patients in daily home oral hygiene care of the teeth and gums, and nutritional supplementation, but also continued follow-up and retreatment to eliminate the infection. The periodontal treatment program is successful beyond my best expectations, with the reduction of periodontal pocket depths from 10 millimeters down to an optimum range of 1 to 3 millimeters. What our office can offer you is the rapid, effective management of your patient's periodontal gum disease with low morbidity, and a paper trail of documentation, letters and reports to you of the diagnosis and success treatment of your patient's periodontal disease. We have a packet of references available and a downloadable white paper with embedded links to pertinent articles. We would appreciate your confidence and gladly accept the referral of your patients to our office for definitive periodontal therapy. Your office or your patients can call our office for a no-charge periodontal screening and evaluation. Major portions of this overview were based on a presentation by Dr. Lee Osler, DDS, and a lecture by Dr. Ari Vajdoni, PhD. I give grateful thanks and appreciation to both of them. Thank you. I'm Dr. Jayson Bromboz. You may contact our office at 727-712-3837 or by email at drbromboz@yahoo.com, drbromboz@yahoo.com. We are conveniently located near Countryside Mall in Clearwater.